your particular situation and needs. The information presented here is not advice, but rather opinions and recommendations from credible sources. Black Health Trust, its representatives, members, employees, attendees, heirs, assigns, and guest speakers and presenters assume no liability whatsoever in connection with the information presented or used by anyone, nor are these discussions directed to specific situations. Again, we strongly encourage all attendees of the program to consult their own legal or medical professionals for inclusive guidance on how to proceed in your own personal circumstances. We are in this together. If this program has been valuable and interesting to you, please visit the website to learn more about our programming and how you can support Black Health Trust so that we can continue bringing our community outstanding content. Visit blackhealthtrust.org. We want to thank the Black Health Trust Steering Committee, the Executive Board, its virtual administrative assistant, our production and Zoom technician, Black Health Trust supporters, and all of the people behind the scenes for their time and efforts that make this program possible. Now let's welcome all of our distinguished physicians and special guests. We thank you so much for sharing your valuable time, information, and educated insights with us today. Your participation and support help to empower our communities of color, and this is critical for our present and future well-being as people. Black is beautiful and knowledge is power. Welcome again, everyone, to the Black Health Trust weekly program. This is our community. This is our time to take care of our health. So lean in, everyone. Dr. Randall Maxey, please do us the honor of beginning today's program.
Thank you very much, Janelle. You look exactly like your beautiful daughter.
Thank you.
Welcome again, everybody. We're so pleased that you're with us. I just returned from my first flight in more than a year to Dallas, Texas. A most rewarding and interesting experience given the philosophical outlay of the demographics in Dallas, Texas. I'll leave that to your imagination. But more importantly, I read another segment of a book that I definitely respect, that I'm going to recommend that everybody on this call read it. It's called Caste. And I've only been able to read it in bites because I can't take the amount of information that is coming out of that book, but it plays directly into our subject today, which is death in custody. So I do recommend that. I rarely recommend a reading list, but that is something that is almost required reading, and I suggest it highly. I'm very excited about the program that we're going to present today. And I'm very excited that the particular person happens to be an ordained minister. But on the side, he's a respected physician and former chief medical examiner of the city. I'll wait for his introduction. But pay attention, take notes. I think this is going to be very interesting. Dr. Barbara Neighbor-Stevens is going to give our statistics after Dr. Ivan Walks takes a minute to introduce her and myself, and we'll get started introducing our program participants. Dr. Walks?
May I have the slides for our folks, please? So if we can go back to the slides for Dr. Maxey and there we go. Dr. Randall Maxey, just amazing human being, is not on this slide, but it should be. He's the 104th president and chairman of the board of the National Medical Association. He's the founder of the Black Health Trust and our leader in this amazing program that is unparalleled. There's nothing else like this that is available for folks to get this kind of information in a digestible, conversational way. It's just a relaxing, comfortable place to be. And we thank Dr. Randall Maxey for making it possible, not just for us, but for people around the world. Next slide, Dr. Neighbor-Stevens. Dr. Barbara Neighbor-Stevens is a graduate of Harvard University and Tufts Medical School. And we could just leave it there if she had left it there. but Dr. Neighbor Stevens has gone on to be a nationally respected, amazing pediatric physician. She served 2 years on the National Health Service Corps. She served as assistant medical director for the Tennessee Bureau of Medicaid, and has just done amazing contributions, including serving as chair of the National Medical Association Pediatric Section. So Dr. Randall Maxey and Dr. Neighbor Stevens have asked me to co-moderate with them the Black Health Trust. It's a great honor. My name is Ivan Walks. I'm a former commissioner of mental health for the County of Los Angeles. I'm a former member of the Board of Trustees of the American Psychiatric Association. And most importantly, I know Randall Maxey. So having said that, I would ask that we turn it back over to Dr. Neighbor Stevens to give us today's statistics and kick off the program.
Thank you, my friend, Dr. Walks. As has been our custom for the last several months, we like to review the COVID-19 statistics as posted on the CDC website. As a reminder, it is updated in the evening, so the statistics that I will be giving you were posted last night. As of last night, there are 33,166,506 cases reported in the United States. There have been a total of 16,520 new cases as of yesterday. The total US death count has, according to the CDC data, reached 593,961. But I will note that you probably have heard a higher number, which I have heard on some of the news services that we have crossed the 600,000 mark. Our total US daily deaths for yesterday were 584, and the total number of vaccine doses given are 300,268,738, which represent the total doses. They may be a completed series for some or an incomplete series for others. Looking at what has been happening with our community regarding vaccine administration, we're not making much progress. They have, CDC has changed a little bit the metric that they're reporting. It really pays to read the fine print. They are now reporting, if you'll notice the different colors of the bars, they're doing it a little bit differently. So the dark red bar is the percent of African Americans or Black non-Hispanic who have received at least one dose of all the doses given. So of that, we are hovering around 9%. Of all US Black non-Hispanic, we have gotten up to 15% of our population, but that's still significantly below the total population. So I don't want you to be confused and think, oh, wow, we're moving up. Well, we did move up, but it's not moving up the way we might want to think that it's moving up. Long story short, we still got a lot of work to do. Black Health Trust encourages you to seriously consider taking the vaccine, and we consider the risk of not taking the vaccine far surpassing any risk that may be associated with taking the vaccine. So we would encourage you to consider taking the vaccine. And then whether you've taken the vaccine or not, use your common sense. If you're vaccinated, if it's an environment that you feel you are not aware of the vaccine status of those around you, that it may be, and it's not well ventilated, it may behoove you to seriously think about wearing your mask. If you're outside and there's plenty of fresh air and you're fully vaccinated, then it's perhaps feasible for you to consider not wearing a mask. But at the end of the day, use some common sense. And with that, I will end the data. We are now going to move on to the main event, as it were. As you know, we are having a conversation today about deaths in custody. And this has been an area of interest of our co-producer today, Dr. Roger Mitchell, since 1998. So I am sure he has a lot to share with us regarding this topic. Dr. Mitchell, as you heard earlier, is an ordained minister. In addition to that, he is a board certified anatomic and forensic pathologist, and as of March of this year, has assumed the role of chair of the Department of Pathology at Howard University College of Medicine. Prior to that, for several years, he served as the chief medical examiner for Washington, D.C. In his role now at Howard, he has the responsibility to oversee the Howard University COVID-19 testing laboratory, and has in the past and currently been very active, as many of us have been, in the National Medical Association. Several years ago, Dr. Mitchell was tapped to be the chair of the Task Force on Gun Violence Prevention, which has been a very active area within NMA, and there has been at least a couple of things published regarding this issue. He is currently the National Secretary to the House of Delegates for the National Medical Association. In addition, he serves on multiple boards, including Mentoring in Medicine, and works with the CDC Foundation, providing technical support to numerous international medical examiners and coroners. Without further ado, I'd like to present to our audience today, Dr. Roger Mitchell.
Good afternoon, everyone, and good morning. I heard someone say morning in some part of the country, so wanted to say good morning and good afternoon. Thank you for the Black Health Trust and Dr. Maxey for finding it important to have this conversation about deaths in custody. It's a conversation that unfortunately is not ever untimely in our community. And so we today, over the next hour or so, want to bring to your attention some thoughts across several of us that are participating in the work and advocacy, research, and academics within deaths in custody or police use of force within communities of color from the physician standpoint. We will hear from my two speakers as well as myself. We will hear from Dr. Mallory Williams, Dr. Donna Christensen, and myself during this program. And you will have opportunities to ask questions. So please, as you're listening to our speakers, please place your questions in the chat. If you don't want to place them in the chat, then write them down on a piece of paper. We will have opportunity for you to ask questions in between each speaker. And then at the end of the three of us speaking, you will also have an opportunity to participate in your own reflection and additional questions and answers that will be moderated by the Black Health Trust leadership. So again, thank you so much for having us in this very timely conversation. And without further ado, we're going to jump right into our presentations. The first presenter in the three presentations today will be given by Dr. Mallory Williams. Dr. Mallory Williams is a professor of surgery and chief of the Division of Trauma and Critical Care at Howard University College of Medicine in Washington, D.C. If we have a slide for his introduction, we can place that up now, followed by his slides that he'll be using for his presentation. He served as a National Institute of Health researcher and scholar in trauma during his surgery training that focused on hemorrhagic shock and won numerous awards for his research and teaching. Dr. Williams is a Commonwealth Fund Fellow in Minority Health Policy and Harvard University's Presidential Scholar. He completed his Master's of Public Health in Health Policy and Management from the Harvard School of Public Health. Dr. Williams is a fellow of the American College of Surgeons and is the previous chair of the Committee of Diversity Issues. He holds the rank of Colonel in the United States Army Reserve Medical Corps and has served in both theaters in the global war on terror. But lastly, him and I, as well as Dr. Donna Christensen, serve on the Gun Violence Task Force for the National Medical Association. And he's participated in the American College of Surgeons Firearms Summit. He's co-author of the NMA position paper, The Violence Epidemic in the African American Community, a call for comprehensive reform. But in this particular, along these particular lines, he's also co-authored a landmark manuscript entitled Patterns of Law Enforcement Related Injuries in the United States, which utilizes the Federal Bureau of Investigation's Uniform Crime Report to describe the morbidity and mortality events related to policing actions. He has so much more that he has accolades for, and he'll be the first to tell you he's a proud Morehouse graduate. I'm even prouder to call him my brother and to have joined him here at Howard University to structure the future of Black medicine in this country. Without further ado, Dr. Mallory Williams. If you'll cue his slides up, he'll be prepared to go. Dr. Williams, can you hear us okay? Dr. Williams, if you're talking, we cannot hear you. You can come off mute, please. Try again.
Is that okay?
Yep, I can hear you now. If we can cue his slides up, please.
The alternative is that they can let me share the screen, but if they can cue the slides, that's great too.
Here we are.
All right.
You're all set to go. Just say next when you're ready to move forward.
Thank you so much, my good friend and buddy, Dr. Roger Mitchell. There was a moderator named Tim Russert who once said, if it's Sunday, it's Meet the Press. I'm starting to feel if it's Sunday, it's Black Health Trust in America. And so it's always a pleasure for me to come and join with good friends with such great intentionality towards this community to discuss items like this. Well, I tell you, technology issues being what they may, if we do get disconnected, don't you worry. I've got a backup plan so that we can still get this thing done. Jimmy Baldwin wrote a book in 1970, If Beale Street Could Talk. And for those who are fans of Jim Baldwin, as I am, we know that Fonnie was wrongly convicted and put in jail, and that broke up a romance that was occurring in a relationship which is the center of that film. It may not have only grossed $20 million in the cinema, but for those of us who love Jim Baldwin, who understand the power of Black love and what it means in the community, we understand that it was a classic. And I kind of patterned the title of my talk today off of James Baldwin's book, If Trauma Centers Could Talk, Policy and Public Health Implications of Law Enforcement Reform in America. Next slide. I promise you no one owns me except one person, and he's in heaven. Next slide. My objectives are trauma center data, to share with you trauma center data on law enforcement related injuries, and also to discuss a little bit about the role that police have historically played in disadvantaged communities of colors. Finally, we'll talk a little bit about our position on the NMA Gun Task Force on Gun Violence on the George P. Floyd Justice in Policing Act, and some of the contributions we have made to openly express that position. Next slide. So if we were to take a jog back to about 2015, Harvard researchers at the School of Public Health, the T.H. Chan School, showed that Blacks were 3 times more likely than whites to be killed by police. And yet, when they showed this data, there were few trauma centers that had produced data about police morbidity and police mortality. It was shocking, and it awoke all of us because we were being called into question, because surely if this was happening, trauma centers were seeing it or were positioned to at least see it. And without saying it, it was basically asking us, yeah, we know there's a blue wall of silence, but is there also a white wall of silence? Next slide. And so, as Roger said, me and a few of my colleagues got together and decided to look at these issues to see what we could see with the data that was available. And so we did this landmark study from 2003 to 2011, looking at data on trauma admissions using the National Trauma Database, using the FBI Uniform Crime Report. And what did we find? We found increase in arrest-related homicides over time. We found increase in justifiable homicides over time. We saw non-fatal injuries increase, assaults on police increase. But we found that non-fatal firearm injuries were more likely in Blacks and Hispanics ages 18 to 39. No one had reported that. And with the E-codes that we were using to develop this data, it was clear to us that we were likely underreporting this phenomenon. Next slide. Next slide. Okay, so no. So when we also look at our colleagues at USC LA County, Schellenberg, they reproduced a similar study. They looked at 2007 to 2012 time period, and they saw in 4 million patients, just looking at the NTDB, they didn't look at the FBI Uniform Crime Report, they just looked at the National Trauma Database. 7,000 injured, and they said 0.17% was the rate of injury by police. And that they said that the injury was stable over time, there was no significant differences from year to year, and most of these were males, median age of 31. But the most common mechanism of injury that they saw by law enforcement was gunshot wounds at 44%. And proportionally, Black patients, more than any other patients, were frequently injured with 3.83 per 1,000 injuries by police being reported. And so these were these 2 documents basically saying the same thing, that there's something happening that's disproportionately impacting brown and Black people in this country as it relates to interactions with law enforcement. And it's peculiar because it's also involving not the baton, not the hand, not the spray, but the gun that the police officer wielded. Next slide. We know that these issues are not new, and I always like to show Gordon Parks's photo depicting Black men standing up and asking police brutality to be done away with back in the 60s, because it gives us a time frame from which we've been dealing and struggling with these issues in this country. Next slide. When we look at Black populations in America, and we look at the percent of Black population in some of our densely populated cities, there is no accident that where you see large Black populations, you also see large density of police. So if there's an average of 17 per 10,000 residents of police in this country, and you look inside of Washington, D.C., where Roger and I work, and you see a 51% Black population, where you see 69 per 1,000. Or Baltimore, where you see 53 per 10,000, or Chicago, where you see 47 per 10,000. These are multiples greater than the average 17 per 10,000. And so we see structurally there is a phenomenon that Black and brown people are to be policed, they are to be watched, they are to be suspected, and if anything looks funny, they are to be over-incarcerated. And that is set up structurally by how we police populations. Next slide. Is there any wonder that 5 times more likely to be stopped by cops are Black men? Next slide. And when we look at imprisonment and we look at the percent population in the country versus the percent prison population, is there any wonder that we're 12% of the country and 33% of the prison population, while Hispanics are 16% of the country and 23% of the prison population? Next slide. You look at every age range, you will see Black men in prison at multiples higher rates than white men. Next slide. And so we have to understand that when we talk about law enforcement reform in this country, we're talking about professional accountability and a restructuring of a police process that goes beyond simply dealing with the death of Black men in custody. That's important. We got to deal with that, and we got to report on that, and got to be honest about that. But we also have to deal with the upstream issues of how we're even structuring police in space and communities, how people are being stopped, and how people are being detained. Next slide, please. We got to be honest with ourselves, and we have to clearly articulate what the prices have been for the things that we have wanted. This is the Presidential Task Force on 21st Century Policing, and it was challenged in many different ways. And the biggest way that it was challenged is that it had a Black face on it. And yet somehow at the end, when the recommendations came down, there was no recommendation to collect one piece of data about a Black person dying in the custody of police in this country. We've got to be honest about that, and we've got to interrogate that. I must admit, since it's Sunday, there's an altar somewhere, and when we're at an altar, we need to alter ourselves. We need to confess in some kind of way. Well, I've had many conversations with the entity that we might call Satan or the devil or whatever. He's never asked me for my whole soul at one time. He's always wanted just a little piece of it at first. And that's the way it is when you are articulate and you are in places of power and you have the ability to do something on behalf of your community. The negotiation and the compromise that don't come as a whole sellout. They come incrementally. Next slide. When we look at the prevention of arrest-related deaths in this country, there are recommendations that have already been made. These are they, 8. And if you review 91 of 100 of the nation's largest police departments, you will see none of these 8 policies in place in all of them. This is pre-Trayvon Martin, not to mention the name George P. Floyd. Next slide. We must go back and we have to be honest with the problems and how they've come about. This is the 1992 paradigm. In 1992, we had the most violent crime ever reported, 13% increase in violent crime, 2 million murders, rapes, robberies, and aggravated assaults. Gun crimes increased to the highest in 20 years. This is what we did about it. Next slide. We passed a crime bill that suggested the more cops we put on the street, the lower crime would go. And what we got 26-year low in crime. But what was the negative impact? Mass incarceration. Who did it impact? Communities of color disproportionately. We passed the Brady bill where we banned assault weapons. Gun crime went down by 40%. What was the negative impact? Mass incarceration. Who did it impact? Communities of color disproportionately. We conducted a war on drugs even further. We increased treatment and prevention funding, and we still ended up with racially biased mass incarceration from the war we conducted on drugs while trying to increase treatment and prevention. And we did economic expansion, which deregulated markets, and I think you know the story behind that, what that gave birth to in terms of the housing crisis. When we talk about deaths in custody and law enforcement reform, We've got to accept a political reality that the move of the Democratic Party to the center, the DLC, okay, meant making certain political accommodations to the political spectrum. It meant being softer on guns in terms of a public message, and it meant being harder on crime in terms of building jails, supporting police activity, and incarcerating individuals. That was the 1992 paradigm. That was what that was about. And the results of that is what we are dealing with and trying to deconstruct right now. Next slide. And so we at the National Medical Association Task Force on Gun Violence have been at the center of this. We have been the most active committee in terms of press statements, in terms of writing recommendations and being active in voicing the opinions of our members on behalf of the Black community. And this is what we've said. We wrote a paper talking about the violence epidemic in the African American community, and we said, listen, we're going to talk about law enforcement related morbidity and mortality as a part of violence in our community, because it is. We're going to rip the scab off and really talk about this thing for what it is. We know police officers pick up gang members on one side of the community and take them to rival gang territories as a way of pitting gangs against gangs. We know that happens. We know that police officers engage in nefarious activities within our community because they can get away with it. Commission after commission after commission has revealed these things, and we're going to talk about it. We talked about death in custody reporting and the need to continue funding that. And we've got a national leader on that who will discuss those issues with you in a minute. And we talked about having accountability for police. Even then, long before George Floyd occurred, we were talking about citizen oversight boards. We were talking about dash cams for police officers and other accountable mechanisms for police. Next slide. We've now written another manuscript and sent it to the Journal of National Medical Association for Dr. Edith Mitchell to consider, looking at the Chauvin verdict and talking and discussing item by item what we feel are items that need to be brought forth as recommendations to improve these issues in our community. We said community members gotta be allowed to videotape police interactions in the public square without being harassed, without being assaulted. We said that there gotta be a federal registry for police terminated for excessive use of force charges. So police just don't prematurely resign and then go to another community, get a job, and continue life and their activities and status quo behavior. We said that when you look at qualified immunity and you take it and you sum it up and you undress it, all it is was judicial activism conferring privilege upon white police officers to do what they want to do to Black bodies. And we need to strip police officers of those privileges when it comes to excessive use of force cases. And we said that a great start would be the George P. Floyd Justice and Policing Act becoming law. And that's not the stripped down law without qualified immunity. That is the law with qualified immunity removed from police using excessive force. Next slide. And so I'm hopeful. And one of the reasons that I'm hopeful is when you look at the Congressional Black Caucus Bipartisan Working Group on this issue, and I can't claim to be an expert on this working group, but what I can say when I look at some of the figures in the working group, there's some of the figures that are here today playing meaningful roles. It's no accident that Keith Ellison is on this working group, and he was the Attorney General in Minneapolis and made the decisions he made as the Attorney General in Minneapolis regarding the Chauvin case. It's no accident that my Morehouse brother, Cedric Richmond, was on this working group, and now he sits as a senior advisor to the president, domestic policy and domestic relations. And Hakeem Jeffries, who was an impeachment manager, was also on this working group. And so I feel that there is the intellectual capital in the Congress to effectively deal with these issues and to bring them up and to navigate them correctly. Next slide. I was sitting in the US Senate Judiciary Committee meeting right after the shootings in Denver with my good friend, Dr. Selwyn Rogers, who was in Durbin's district, and we were giving testimony about gun violence. And one of the things that I can say was shocking to me was that the sides on these issues are so entrenched and so backed and funded that sometimes it seems hard to make the kind of progress that we would like to make. And yet there is a way somehow, and you can kind of see that developing and molding in some kind of ways. And so I'm proud to say to you today that even though we kind of get stuck, I'm optimistic, and I appreciate the Black Health Trust giving me the moments here to share with you my experiences and my thoughts on the issue. And I look forward to the question and answer period. Thank you so much.
Thank you very much, Dr. Williams. Let me ask a question, if I might. I would like, as a physician, and I'm only being partially humorous, to have qualified immunity for me. What exactly is qualified immunity in the sense that you're speaking about it for our audience?
Yeah, it basically creates a higher threshold, a higher legal standard by which you can bring accusations for the behavior of police officers. And those standards are very unreasonable, and they can be interpreted differently across legal jurisdictions by different judges. And so what one judge may say is okay to bring as charges against a police officer, another judge may say, no, that's acceptable in this jurisdiction. This police officer can do that because previously by this court, by this decision, this was allowed. And so it's not just by what we see with our eyes. It's by any legal opinion. Any lawyer can go get a previous case and show that something previously was allowed and rest their defense on that case, and then immunize that officer, okay, from his actions, no matter what the results are. Okay, so it is a halo. Okay, Supreme Court Justice Sonia Mayor said it best. It is a halo that immunizes the police to do anything that they want to vulnerable people in this country.
Is there any reason in thought and intellectual review of why that applies only to law enforcement and not to healthcare, where we're trying to save lives?
Mm-hmm. Yeah, it has a broader application to civil servants, actually. So I don't want to suggest that it's just purely something applied to police officers. We're talking about it now more prominently as it relates to police, but it does apply broader to civil servants. And some would say that it probably should apply to civil servants and not to police, but police are civil servants. So that has been adopted. We have something, Dr. Collier, that looks a little bit like qualified immunity. If we are assisting in a national disaster, so Katrina or an earthquake, we come into the assistance of that region under the rubric of FEMA. We are immunized against malpractice in that setting if we're under the rubric of FEMA. And so we do have a little bit of a privilege similar to qualified immunity. It is not as sweeping and it is not as certain, for sure.
Dr. Mitchell?
Thank you, Dr. Williams, for that overview and leading us into this discussion. I do want to give an opportunity, if there are any other, I think we may have some time for maybe 2 more questions directed towards Dr. Williams. We will do some overlap on some of these topics that he's laid out for us. Both with the George Floyd Policing Act, which Dr. Christensen will cover in part, and I will cover in part, as well as deaths in custody in general. And I know that Dr. Faget just put a question in the chat, and we'll make sure that we get to that in a moment. I'm going to share my screen.
Hold on, Dr. Dr. Mitchell?
Yes.
If I had a bit, I would be chomping at it.
Please.
First of all, Dr. Williams, thank you so much. It is so important that we hear things explained ordinarily, practically, simply, so we can understand it. And Dr. Maxey, before anybody else gets confused, the Good Samaritan law ain't, to use the proper English, it ain't qualified immunity.
Right.
Sometimes they let us, because we're trying to do the right thing, we're not in as much trouble, but qualified immunity, as Dr. Williams really stated, is something absolutely different. My question is this: when you went back, Dr. Williams, and you went through this 1992 sort of construct that came out of it, it kind of could look like we're asking people to choose between being safer because crime goes down when you lock Black people up, not your words, mine, and not being as safe because we don't want to do mass incarceration and we don't want to abuse Black people. Well, if I'm not Black, I'm saying, wait a minute, didn't you just show me that if we beat Black people up and we lock Black people and brown people up, that overall crime is down and I'm safer? How do we respond when we get that kind of an interpretation of that data?
I think that's a great question. That will naturally emanate from immature minds. So we have to be prepared to respond to these types of inquiries. And there are a lot of things that we can say to that. We can mandate that everybody run 5 miles a day in this country. And we can get rid of a lot of obesity-related illness and then lower healthcare costs. We suggest that in America, there are personal liberties and freedoms, and we build the country based upon those personal liberties and freedoms. That's where we start. We do not start outward. We start with the premise that freedom is essential to the democracy. And we embrace the fact that within our enshrinement of freedom, that there's some things that come along with that become a little bit more uncertain. And so let's go to broken windows policy in New York. 80% brown and Black people delayed as they walked the streets or stopped inappropriately. That's what the data says. Crime went down. Everybody got excited and praised Giuliani. But how many Black and brown people's lives were disturbed on behalf of that? And so at one point in time, we have to ask America, is the fundamental premise applicable to Black people, right? Is freedom precious when it's Black freedom we're talking about? Or is freedom just really precious when it's somebody else's freedom we're talking about, right? And this is when I ask my conservative colleagues, are you really conservative? Or are you racist? Because there's a difference. Okay, all right. So I think we have to always stand up and speak in this nation based upon the American values that have been put forth historically to describe the nation, okay? And then hold the nation accountable to those values, right? So if it's liberty and justice for all, and if that's what the documents say, there ain't no conjunction to say except or but for, then we need to adhere to likely those principles as it relates to all people. And I think what you hear my Morehouse brother Eddie Glaude on MSNBC speaking toward most of the time are the stories that we tell ourselves in this country, which is that we really don't include African Americans in the story of this nation. And so when we talk about depriving them of their rights, or we talk about inconveniencing them, that's okay, because in the narrative, they're not really American, right? There's something else, which can vary from day to day. And we have to continually put forth that, in fact, yes, we are American, and we have fought heartily for this country. We built the economy gratis, and we fought in every war, even when the rights of the country and citizenship were not bestowed upon us. In fact, if you want to measure citizenship in this nation, you may not find a more American than someone who's African American.
Amen.
So I would also just add to my brother's comments is that if you look at the research and literature, access to education, economics, those studies, when placed and this access increased amongst African American youth, they actually have a more sustainable outcome towards decreasing violence than does incarceration. So if there are individuals that want to use the incarceration as a metrics for safety, though incarceration doesn't last, it's a non-lasting, it's a temporary solution towards violent behavior. What's more sustainable towards violence prevention is those structures that are reminiscent of a surrogate family structure. So caring, consistent caring adults, and then access to education and jobs have a more sustainable violence preventative outcome than does placing people in jail. And so if we're really talking about trying to decrease violence and increase safety, then we want to go towards those that are more sustainable.
Dr. Mitchell, do I hear a subtle implication that the only crime is violent crime? White collar crime is not as bad a crime. If you steal $1 billion and destroy a family, isn't that violence as well?
You know, and you're speaking to the whole construct, right? I mean, you know, it's structural and institutional racism and those things that destroy whole communities are seen as allowable, and then those or less than in severity, and those that occur in violence, neither of which should be acceptable. And that leads us into the presentation that I'll give. We're talking a little bit about deaths in custody, and you heard about it. I'm just happy to be here and making sure that we're having this conversation to equip these such astute and accomplished Black physicians in this country about this topic, and those of us that are in community that think it's important. I have no disclosures. My opinions are my opinions. Don't attribute them to Dr. Frederick. I might, that might not be attributable. They're my opinions. I have no financial disclosures. I thought it would be important to start with the Tulsa Race Massacre of 1921, understanding that we just achieved 100 years since that race massacre. Some call them riots. Riots were being used, the word riot when white Americans were killing Black Americans were used to ensure that insurance policies did not pay Black loss of life and Black loss of business. And so when we talk about what has happened in Tulsa, we have to talk about it as it relates to it being a massacre, and it being one that is perpetrated on people, Black people, successful people in this country. It becomes important, and you might ask, well, why do you start here when we're talking about deaths in custody? These types of race massacres that have been highlighted by our own Ida B. Wells in the Red Record, the lynchings that have happened in this country, the extrajudicial violence, mob violence that was allowable and sanctioned by government in this country, has had and it was in the 1950s, 1940s, 1950s, that there was a successful handoff from mob violence, extrajudicial mob violence, to state sanctioned violence by law enforcement. And lynchings and deaths in custody are on a direct continuum as it relates to the death of Black people in an extrajudicial construct. And I wanted to make sure that we pointed out that as we understand deaths in custody in this country, that we make no mistake that it is directly connected to our position within this racist structure. Some of you may remember the famous song by Billie Holiday called "Strange Fruit" that laid out this hanging of Black men and how common it was of Black men and women to hang in a way that did not allow for them to receive a proper day in court. And so we're seeing these things play out in our day-to-day today. There's a recent article that came out in the American Sociological Association that talks about the coroner constructs of white innocence in the postbellum South, exculpating the injustices placed upon Black bodies during the height of the lynching. During that Tulsa race massacre, the coroner had found that there were no individuals that were responsible able to be found. And when there was in a coroner system, when that coroner system could say there is no identifiable agents that could be found, that means that there would be no coroner inquest. And when there was no coroner inquest, then there would be no criminal proceedings. And so for lynchings throughout our history, the coroner, who we've evolved now to the coroner being the medical examiner or the forensic pathologist, which is my profession, that coroner would stand in the shadows and make distinctions that functionally exculpated the fact of lynching in this country. That has not yet, that story has not yet been told. And so I'm in the brinks of about to tell that story. So we know that in deaths in custody has been brought right now to the brink because of the loss of George Floyd. You heard earlier that the National Medical Association, even prior to the death of George Floyd, placed an article called "The Violence Epidemic in the African American Community," a comprehensive, a call for comprehensive reform. That in it, we talk about the need for changes within deaths in custody, and we'll talk about that shortly. But first, let's briefly remind ourselves of the definition of structural racism, which is a system of in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. It identifies dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. Structural racism is not something that a few people or institutions choose to practice. Instead, it has been a feature of social, economic, and political systems in which we all exist. And so just a history of this structural racism, W.E.B. Du Bois talked about structural racism and other social problems. He said, the Negro death rate and sickness are largely matters of social and economic conditions and not due to racial traits and tendencies. And so our battle against deaths in custody is not function of our Blackness, but a function of the structure that creates racial inequities. In this study that was published in the NIH Public Access, and the manuscript that you see to the left, there is an argument surrounding Healthy People 2010. Now we're in multiple iterations of Healthy People, that the elimination of disparities, the magnificently democratic goal of Healthy People 2010, or you pick it, 2020, cannot be achieved without first undoing racism. And so this construct of racism is one that has to be dealt with if we're going to deal with deaths in custody. We know through our history and the continuum that has led from the American slavery to mass incarceration. And we're living in this environment of mass incarceration. And why does that becomes extremely important? Because you saw the statistics that Dr. Williams placed, that we have a disproportionate amount of African Americans, men and women, in our prison system. And our prison system is functionally, if you ask me, if done properly, really should be thought of as a healthcare delivery system, not a carceral system, not a punishment system, because everyone in that system is suffering from some health issue, one or another. Mental health being one of them, substance abuse being another, diabetes, hypertension, obesity, you name it, cancer, you name it. There's individuals within the carceral system that are suffering disproportionately from healthcare issues and have a higher morbidity and mortality because of how they're housed and treated within our carceral system. So the health delivery system within our carceral system is also on the continuum of the deaths in custody, if we're interested in why people die while in custody. And then in custody, I'll just tell you in a moment what we're talking about when we define deaths in custody. Those that have read this fantastic book, if you have not read it, by Richard Rothstein, The Color of Law, and how functionally the redlining occurred, particularly in California and places like Compton, that occurred. These are the types of things that really started setting aside African Americans into areas where their healthcare and how they were treated by law enforcement continue to be disparate. This is a brief diagram, again, showing the continuum of this 13th Amendment, that you weren't allowed to be held in bondage without rights unless you were convicted of a crime. And if you were convicted of a crime, then it was as if you were a slave. Until to this day, those individuals that are convicted of a crime are treated less than human if we were treated as humans before. And this becomes important because we will talk about 1 out of 3 Black males will go to prison. So the Black men on this call, there may be some that are hiding their prison time, but there's others that we're showing that we're defying the odds because we placed ourselves in this concentrated community of excellence. It becomes saturated when we decide as prominent physicians and physicians with voice to go into community and be part of community and operate in community, not as community as those individuals over there are suffering from violence. Those individuals over there are going to jail. But if we live and operate in community, we can understand that it is us that is going to jail. It is us that are in slavery. It's us that are being lynched. And so I would submit to you that if it was 1877, that you too still would be free. You too still would be a physician. You still would be prominent and accomplished. But those people that look like you would still be getting lynched by the people that we're fighting against. So the question is, would you have been an abolitionist? The question is, would you have been fighting on the front lines to decrease lynching in this country when lynching was prominent? And so right now in deaths in custody, what are we doing as Black physicians and physicians in general to decrease deaths in custody? Because it is a public health issue. So Stokely Carmichael, a Howard graduate, said it best. He knew it before it was called social determinants of health. He said, and I'll start from the middle. He says, and thousands more destroyed and maimed physically, emotionally, and intellectually because of conditions of poverty and discrimination in the Black community. That's a function of institutional racism. And the reason why I show this slide is because there are only a handful of genes that code for the skin color of the human species. These skin colors are not connected to deaths in custody. We're doing a series on excited delirium, and I'll be sending it out to this group to be a part of June 25th and 26th. We're having an international conversation about excited delirium. And that excited delirium functionally suggests that the Black man self-combusts when engaged with law enforcement. It is a unexplained phenomenon of death that occurs amongst particularly Black men in the custody of law enforcement in an altercation. And so there's opportunities for us to have this discussion, none of which is coded to the genome of the color and hue of our skin. So disparities in social and health outcomes are not a function of the color of one's skin, but the function of one's social and structural inequities that exist within one's community. And that quote is my quote. So let's talk a little bit about the likelihood of being placed in jail, and we'll talk about deaths in custody. 1 out of 9 in all men will be placed in jail or in prison. 1 out of 3 are Black men. 1 out of 56 in all women. 1 out of 18 in Black women placed in jail or in prison. So it becomes important what happens during connections with law enforcement. If 1 out of every 3 Black men, and I can't see everybody's hand, but I will ask the Black men on this line to raise your hand if you've been detained by law enforcement for any reason at all. And so if you take a quick peruse, you'll see that there are a majority of Black men's hands went up. If you're a Black woman, have you been detained by law enforcement for any reason at all? Right? And so this notion of the interaction with law enforcement and what happens during that interaction becomes of grave concern to those of us that are concerned about Black health in this country. And it becomes important because not all, this is just the likelihood of going to jail and prison. Imagine the numbers of just interactions with law enforcement in a detained of some reason of some sort. Becomes extremely important for us to understand this as a public health issue, because we understand coming into contact with law enforcement like coming into contact with a cigarette. Coming into contact with law enforcement like coming into contact with a motor vehicle collision without a seatbelt. Coming into contact with law enforcement like coming into contact with a collision on a bicycle without a helmet. There's significant morbidity and mortality in this country if you come into contact with law enforcement or the criminal justice system or go to jail and prison. And we need to understand it from a public health lens. So our colleague, Congressman Bobby Scott, made it important for us to understand what it meant for us to record data surrounding deaths in custody, called the Deaths in Custody Reporting Act. The HR 1447, which was signed into law in 2013, can I tell you, it is 2021 and there has not been a report at all on deaths in custody as it relates to the compliance to the Deaths in Custody Reporting Act. Not at all, not under Obama, not under Trump, and still not under Biden. Let me just let that seep in. There is a call, a mandate by law for every law enforcement organization to report their deaths in custody. And it has not been reported to the American people to this date. I had a conversation with Representative Bobby Scott last week on Thursday. And he's still fighting to get this fully implemented by the Justice Department. And so we'll see what Biden does under his Justice Department. So when we talk about definitions of deaths in custody, so you have particular understanding. Deaths in custody can be separated into 4 categories, excuse the misnomer. Distinct phases. Deaths that occur during the apprehension or pursuit of those individuals by law enforcement, deaths that occur during restraint, transport, booking, intaking, and holding, deaths that occur while in jail or in prison, and deaths purposefully conducted by the criminal justice system. This is important for those of us that treat these patients in our emergency departments, our ICUs, and our surgical suites, as well as those that are forensic pathologists. There may be overlap of these phases. Therefore, the medical examiner must carefully review all records prior to making this distinction, and all physicians prior to making this distinction. And so again, the phases of deaths in custody start during the pursuit. So if they're running after these individuals, and a death occurs, that's a death in custody. If there's a high-speed motor vehicle chase, and that individual flips over in a vehicle and dies in that motor vehicle chase, that is a death in custody because of the pursuit. And then obviously during apprehension, and then you see this ankle monitor. Some believe that post-custody is an area that we need to be looking at. Those of you that know this work know that individuals that get out of jail have a higher propensity towards overdose. They have a higher propensity towards suicide. They have a higher propensity towards actually cardiovascular deaths because they were getting medications while they were inside jail. When they get out, because of the lack of access to healthcare delivery and the lag, they may not have access to their dialysis treatments. They may not have access to their cardiovascular meds. And in post-custody phase, we see a lot of cardiac deaths among those individuals that were in custody. All of these are issues of public health concern, particularly because of the volume of Black men and women that are engaging in the criminal justice system, both inside and outside of the jail. And so the National Medical Association position paper, National Association of Medical Examiners position paper on recommendations for the definition, investigation, postmortem examination, and death reporting of deaths in custody. I led this charge back when I was a member of this organization to make sure that we had a standardization of medical examiners and coroners that are doing this work. Prior to this paper that occurred in 2017, the same year that the NMA paper came out, there was no standardization of how deaths in custody should be handled by the medical examiner and coroner. So this was an attempt to create some standardization on how these cases are investigated, reported, and examined. This also exists in the violence epidemic paper by the NMA. One of the biggest things that we're asking for, and I'm almost done, is the inclusion of a checkbox on the U.S. standard death certificate. One of the questions that you might ask on this call, what can we do? Well, listen, your local vital records department has an electronic death record that is signed by physicians in hospitals and signed by physicians in general that has check boxes on it. Maternal mortality is on the U.S. standard death certificate. Were they pregnant when someone died? Smoking check boxes on the death certificate. Were they smokers? Were they operators of motor vehicles or passengers or a pedestrian is on the standard death certificate. What is not on the standard death certificate is, was this individual part of in custody when they died? Was it were they in the pre-arrest, arrest, in custody, jail, or incarcerated? And why is this important? Because this provides a public health third-party objective measure to identify individuals that are dying in custody and would work alongside the Deaths in Custody Reporting Act that requires all law enforcement to report individuals that die while in custody. And so it would create reliable and reproducible data, national uniformity of certification, create an educational module for what deaths in custody are, and then field development. Public health researchers, PhDs would be developed on deaths in custody if we have uniformity of practice on how these deaths are reported. So while I was the chief medical examiner of Washington, D.C., we developed a checkbox on our local death certificate. So right now, for the last 5 years, it took me about 2 years upon my arrival to get this checkbox put in place. That death in custody checkbox is on the electronic record for individuals in the District of Columbia. And you can see it there. Yes, no, or unknown. Very easy. And it's based upon whether it was pre-arrest, arrest, in custody, or incarcerated, as it relates to definition. So I got a couple examples. This is a 47-year-old man with no known past medical history, presents to the infirmary at a local state prison complaining of acute abdominal pain over 3 days. He was a witness cardiac arrest and transferred to the local hospital where he died. Here he is. You can see him here. He's intubated. He has a tight belly. That's the first thing that we identify here in him. And then, excuse the gross nature of the slides here, you have a rip-roaring peritonitis. Here, you can see the dusky brown of the dilated small loops of bowel with areas of pus. And then you see here in the opening of his stomach, he has a duodenal ulcer. And he has a perforated duodenal ulcer here. This is the outside. You can see that there's some healing areas there. So there's some level of chronicity to this perforated duodenal ulcer. And this is the peritoneal fluid, this purulent peritoneal fluid of 3,000 milliliters of pussy fluid in his abdomen where he died of sepsis. In America, where over-the-counter medications and a quick visit to a primary care provider can stop you from even developing an ulcer, let alone a perforation of an ulcer that causes death. A man dies in prison from what is a treatable disease process. So we call it septic complications of perforated duodenal ulcer. We call this natural. Question is, what in custody phase did this death occur? The custody phase would be the incarceration phase of the deaths in custody. But you can see it's a natural death occurring in a death in custody. And this is important because we believe that all deaths in custody are violent in nature. All deaths in custody are perpetrated by law enforcement against individuals, but that is not the case. Deaths in custody manners are from all the way from naturals all the way to homicides and even some undetermineds. But it's important to understand it through these phases so that we can fully understand how interaction with the criminal justice system leads to increased morbidity and mortality in this country. And right now, we don't know the answer to that question because we're not recording the data to that question. The second and last case is a 23-year-old Black man encountered police during the commission of an armed robbery at a convenience store. Witness state that he pointed the weapon at police while in pursuit. Here he is. He's shackled in the back because all individuals get shackled when they're in pursuit, being pursued by law enforcement. He's shot in the back and there's a palpable projectile in his chest. At autopsy, he has a wound to his back that is right to left, back to front, and upward. There's no stippling or soot to suggest there was close contact. This is a flay that we do on all individuals to make sure that we have an identifying whether or not there's any evidence of bruises deep to the skin surface, particularly in individuals that are dark skinned. And then there's a hemorrhage here in the chest. There's perforation of the heart and the lungs and recovery of a projectile. His cause of death is gunshot wound of the torso, homicide. Because he was not engaged and was running away from law enforcement when he was shot, what in custody phase did this occur? This would be the pre-arrest phase of a death in custody. So with that, we understand what brought me into this work back in 1998 when I was a first-year medical student. Amadou Diallo was killed. He was shot at 42 times. He was hit 19. He had entrance wounds in the soles of his feet. He was reaching for his wallet in the vestibule of his home, where he was shot to death by law enforcement. Those law enforcement were tried and not convicted. He was on his back when he got shot. He had acute angle entrance wounds, soles of his feet coming out of his abdomen. Right then, as a first-year medical student wanting to be a forensic pathologist, I knew deaths in custody was a public health issue, and wrote the first paper on police brutality as a public health issue in the Journal of the Student National Medical Association in 2000. Philando Castillo, I was his medical examiner for his family when he was shot, with his 6-year-old daughter in the back seat and his girlfriend in the front seat. He was a card-carrying member of the NRA and had a legal ability to carry a weapon. Mallory Williams will tell you that he is a gun owner. I too am a gun owner. I'm a student of Negroes with Guns by Robert F. Williams and the Deacons for Defense. Philando Castillo. And then George Floyd. Just like Amadou Diallo, George Floyd and I were the same age when he got killed. Him and I would have watched the same cartoons, played the same games, same video games, ran in the same way, watched the same cartoons, ate the same breakfast and lunch. And let me tell you, when he died, I felt an air of guilt, survivor's guilt, that could have been me at 46 years old. We just, on May 25th, just commemorated a year from the death of George Floyd. And so we have to understand what our biases are, because I could have just as easily been George Floyd if you found me in my backyard or on a weekend, not with a blazer on in front of you, very important people, but on a block in front of my godbrother's barbershop. And so we have to understand that our bias is something, and the bias of this country is something that we have to work towards. We just also, Breonna, we just celebrated her birthday, right? Just happened, I think, this week. My daughter came up to me and said, Breonna Taylor's birthday was this week. That's my daughter, 16. Remembering this young lady. And this man, when people were kicking down his door, what did he do? He shot at the people coming into his woman's apartment because he had a legal ability to have a firearm. And if you're kicking down his door, then he has to protect his family. No-knock warrants is something that we see in the George Floyd Policing Act that we have to get rid of. And guess what? If someone ran up in my house and my woman was there, that's my wife of 19 years, then guess what? I'm going to be doing the same thing in my house that young man was doing for Breonna Taylor. So we have an opportunity here to bring forward all the things that we know about medicine and public health and bring it to bear surrounding deaths in custody and surrounding misuse of force by law enforcement in this country. And I hope that we can do that and have the ability to put the necessary pressure on our senators to pass the George Floyd Policing Act. So I will stop sharing here as we ask any questions that you may have of me and prepare ourselves to have a conversation with our illustrious Congresswoman Donna Christensen, and a larger conversation across the lines of deaths in custody and police use of force.
Dr. Mitchell, outstanding. And my main comment I'll make at this time is amen. We must follow your direction. I think Dr. Neighbor Stevens wants to lead off the question.
Thank you, Dr. Maxey. And actually, I would appreciate a response from both Dr. Williams and Dr. Mitchell to my question. My question is, my comment is, you have given us a plate full to digest, and I'm sure that we all are going to reflect over the next several days on different things that you have highlighted in your talks. But as always, I want to bring this back to what is it that we can do, remembering that this is not an audience of just physicians. This is an audience of the community as a whole. And yes, we want to get the George Floyd bill passed. But you also suggested some other things that I'm not sure exactly how to translate the need into definitive action. So if you two would care to guide us in how we can be more efficient in helping to address the multiple layers that you have laid out for us so far, because I know we got more coming.
Yeah, we do got more coming. I'll just jump in real quick. One of the big things, and again, I've been talking about a checkbox on the U.S. standard death certificate for deaths in custody since 1999. And as a student, didn't know who to talk to. And now we're getting close. We're getting close. But I think that those of you that are in community, whether you're a physician or not, you can ask your public health director, your director of the Department of Health, is there a way to track those individuals that die in custody? And then advocate for that box to be placed on the on the U.S. standard death certificate. We talked about the George Floyd Policing Act. So I think that, to make it plain, writing or calling or emailing your local Department of Health director and asking them to place a checkbox on the standard death certificate, on their death certificate, to track those of us that are dying in custody, I think is extremely important. And I'll pass it over to Dr. Williams for any comments that he might have. You're on mute, sir. You're on mute, sir. Sir, you're on mute.
There we go.
All right, there we go. So I think a couple of things. I appreciate the question because it really gets into the role of citizens year round, right? And, a lot of us had to be very diplomatic in pressuring the Obama administration. Black Attorney General after Black Attorney General, Police Commission, yet a full report that said nothing about collecting data about Black people, really all people, but we were concerned about Black people because they were disproportionately represented in the deaths, police officers. And so how do we be supportive? I voted for him twice and gave him more money than I ever gave a politician before in my life. But the Negro was wrong. And a lot of our community are not poised to critique political allies out of somewhat rational fears. But yet, the best interests of the entire community have to be placed sometimes above those of the Black middle class. We don't like to talk about that. Okay, sometimes, we pay a little extra taxes and we take a little hit on behalf of our whole community. It's called, unity, umoja. We have to be ultimately concerned about who our district attorneys in our local jurisdictions are. We have come to the place and the time in this discussion where we have seen too often that prosecutorial discretion is important. It may be more important to our community than some of these other issues that's going on in the mayor's and the governor's office. And so we have to pay attention to who becomes attorney general and who becomes district attorney. That has to be kind of our focus in our community. And so the debates that occur, that our sororities and our fraternities, the forums that they hold, have to have a focus on who are the prosecutors and what are their records and what do their records say as it relates to how African Americans are dealt with in the legal system. I think we also finally, we have got to be energized, okay, in every aspect of the electoral system, right? And so I can tell you, I don't like it that Cory Booker is negotiating the George P. Floyd Justice for Policing Act. I don't like it that he's the negotiator, because I showed you a picture of people who have historically been involved in this issue. He Black, and he wasn't on that picture. Doesn't mean that he can't do a good job negotiating the issue. It just means that from a historical standpoint, understanding the contours of the debate, understanding the subtleties of how the other side will move pieces around to try to manipulate and contort issues to get to a standpoint of nothing getting done, there may be a little bit of naivete and there may be a little bit of complicitness in that, okay? I would trust Maxine Waters. I would trust Hakeem Jeffries. Okay, I would trust my sister in Texas a little bit more on those issues than Cory has earned at this point in his career. That's not a knock against the senator from New Jersey. That's just me being politically tuned in to the historical argument and saying these people have more political bona fides in the area, right? And so we have to be in tune like that. We can't let people just put a black face before us and we say, okay, he's got that issue and therefore it's going to be okay. We have to ask even our allies, well, why is Cory, and don't get me wrong, Cory's on the Justice Committee, is on the Senate Judiciary Committee, okay, and he has strong positions on these issues, but again, historically, who has the credentials? Who has fought the fights? Maxine has fought these fights, going back to Reginald Denny. And so I look at these things and I make these assessments, and I understand the necessity for an empowered, enlightened community and electorate on our side in terms of engaging in this type of dialogue. Thank you for the question.
I thank you so much, and I'm afraid you're telling too much truth. Too much truth. We need to listen to that. Dr. Walks?
Dr. Walks, before you ask your question, I just want to make sure, I really want to make sure that the Congresswoman has enough time to give her comment. So whatever questions you have, if we can be brief.
Dr. Mitchell knows me well, and I need that. Thank you, Dr. Mitchell. Let me make one quick comment. There was, and I'm sorry for this, Dr. Mitchell, but I think it's important. Dr. Williams made a comment, and in that comment was a reference to former President Obama as a Negro. And there was a question in the chat about whether that was meant in a disparaging way. And I'll answer on behalf of my brother, Dr. Williams, that when we're talking amongst ourselves with family, we say things in a way that we wouldn't publish in an op-ed in the Washington Post. So I can say on behalf of Dr. Williams, it was not meant in a disparaging, but more of a colloquial way as he was talking with us. And I'll just use my time to say that.
Thank you, Doc. Our next speaker is the Honorable Donna Christensen, retired from the U.S. House of Representatives in 2015, where she served 9 terms. She is the first female physician to serve as the member of the House of the U.S. Congress in the 111th, 112th, 113th Congress. She's a delegate. Christensen served on committees on energy and commerce, on its subcommittee on health during healthcare reform. She also served on committee on Homeland Security, the Committee on Natural Resources, and the Committee on Small Businesses. Congresswoman Christensen chaired the Congressional Black Caucus Health Brain Trust for 16 years. She practiced family medicine and served in several public health administrative positions prior to her election to Congress in 1996. She recently established the Christensen Institute for Community Health and Empowerment. Dr. Christensen is a board-certified board member of the Consumer for Quality Care, American Kidney Fund, Black AIDS Institute, and several other boards and institutes. She currently serves as a public health advisor to the Virgin Islands.
Roger, you're talking longer than I'm going to speak.
I know, but I have to give you your due. So without further ado, Dr. Christensen.
Thank you, Roger. And it's such a pleasure to be a part of this conversation. And really, the meat of the conversation that we're having today has really already been given. But I want to thank the Black Health Trust for having us here. Dr. Faggett has been telling me about the trust for a couple of months. This is my first time to be a part of it, and I will not be my last. And it's good to see so many people who I have worked with over the years who've been involved in the elimination of health disparities and closing the gaps in health equity for our people. And so this puts us right in the public health space where this conversation belongs. And when I just want to underscore something that Dr. Mitchell said when he talked about education and economic opportunity, because when you look at all of the public health challenges that our community face, it's always the social determinants of health that must be addressed if we're going to have if we're going to make any change at all, if that change is going to be sustainable, and if we're going to build a resiliency in our communities to withstand whatever comes, whatever the next COVID is, whatever the next hurricane is, whatever is coming. So I wanted to underscore that also. And we've talked a lot about, and this whole conversation really is about the legislation. And we've talked about the social determinants of health, but I just wanted to read a little bit from the political determinants of health, because that's really what we're talking about. How do we affect the politics, the policymakers, to make the changes that are necessary, like passing the George Floyd Justice and Policing Act, which was passed on March 3rd in the House. And here we are on June 6th, and we haven't been able to get it through. And that's what prompted the letter that we sent to Nancy Pelosi, to Cory Booker, to Tim Scott, and to Karen Bass, saying that we wanted to weigh in on this negotiation. It's taking too long, and particularly we wanted to weigh in on the elimination of the qualified immunity, which has been this sticking point of all of these negotiations. But let me just go back to the political determinants, because that's where it has to start. If we don't change the politics, nothing is going to change. So the political determinants of health, as defined by Dr. Brian Smedley, someone else that I've worked with over the years, the political determinants of health involve those systematic processes of structuring relationships that we've talked about, of distributing resources and administering power, operating simultaneously in ways that mutually reinforce one another to shape opportunities that advance health equity or perpetuate, and exacerbate health inequities. And the author of the book, The Political Determinants of Health, Dr. Daniel Dawes, says, these political determinants of health are the instigators of the causes of inequities, the determinants of the determinants, which have a cascading effect on our health and our life. So just to underscore what Dr. Williams was just saying, we must, if we're going to make change, we must interact, we must advocate with our elected leaders, our policymakers on every level. Does everyone know what's in the George Floyd Justice and Policing Act? I can give you a little bit of the headlines, but we don't have a lot of time, and I just want to make sure that we have enough time for questions. So it would end racial and religious profiling. It prohibits federal, state, and local law enforcement from racial, religious, and discriminatory profiling. It bans chokeholds and no-knock warrants. Requires a deadly force be used only as the last resort, and requires officers to employ the de-escalation techniques first. It limits military equipment on American streets and requires body cameras by every policeman. It holds police accountable in court. This is the sticking point, the elimination of the qualified immunity for law enforcement. It investigates police misconduct. It empowers our communities. It establishes, for example, public safety innovation grants for community-based organizations to create our own local commissions and task forces to help our communities reimagine and develop concrete, just, and equitable. Where did I go?
We still see you.
You still see me? Okay. And you can hear me. Okay, and then, of course, enhances the reporting. It probably doesn't go as far as Dr. Mitchell would like us to go, but there's an improved transparency and data collection and reporting that must take place, and it stops sexual assault in law enforcement custody, something that I had to deal with women in custody when I was in Congress. So basically that's it, and it involves, of course, a lot of training for police. Now, I had an opportunity, we've talked about several of the members of Congress that are key for us to interact with, and I agree, Sheila Jackson Lee, and of course, Benny Thompson, who chairs our Homeland Security Committee. Sheila chairs the Subcommittee on Crime, Terrorism, and Homeland Security in the House Committee on Judiciary. Bobby Scott, who heads up Education and Labor, and Robin Kelly of the Health Brain Trust. But we have many, many other members who are chairs of committee that help us to get to those social determinants of health. So I had an opportunity to speak with Sheila this weekend to find out exactly where they were. And Dr. Williams, you'd be glad to know that she's very intimately involved in these negotiations. So not to worry. So, first of all, I sent her and I sent Clyburn the letter as well. And she thanks everyone for that letter. She plans to utilize it in many different forums. And she urges us to continue to advocate for, as we have done in the letter that we sent to her. This is where they are. The House is out in the community right now, but the Senate comes back in tomorrow. And that's where the problem is, of course. And she feels that perhaps there'll be some news coming out in the coming week or so that maybe the problems are not completely resolved, but that they're making some headway. So we'll wait and see what we hear from the Senate when they come back in next week. But the issues that are still holding up a resolution and a reconciliation of the House bill and what the Senate wants is, of course, the qualified immunity. They are at the point of wanting to define what excessive force is that might or might not qualify for the qualified immunity. And of course, we're fighting back on that. It has to be eliminated, period, because the law enforcement will still feel that they have a right to excessive force and have ways to get around anything that is not a complete removal of that qualified immunity. The other issue is an issue about what constitutes a criminal act. What's the threshold for a criminal act by law enforcement? Right now, it's willful excessive force, willful injury to someone in custody. And they are trying to move that down to reckless, a reckless act, which is a lower threshold and will really capture more of that the excessive force that the law enforcement is inflicting on our communities. So they're hoping to be able to do that. And on the militarization of the police, of course, the Democrats and Sheila in particular, they're fighting to have it eliminated entirely. It's probably going to not be eliminated entirely, but it will be very much limited, she feels, when the negotiations are over. So that's where they are as of right now. And I'm going to stop here because there may be questions that I haven't covered in just breezing across the bill. I'm sure there are other questions also for some of our other speakers. And I'm going to try to figure out how I get back on this.
We can see you and we can hear you, Dr. Christensen.
Okay.
Thank you, Dr. Christensen. Really appreciate that. Dr. Mitchell, can I see if our hostess sees any questions in the chat?
Absolutely.
Janelle?
You're on mute, Janelle.
Are you muted, Janelle?
I don't see any questions related at this time.
Okay. Then Dr. Mitchell, would you lead off with our discussion and questions of yourself and the others?
Absolutely, absolutely. I want to go back to you, Dr. Christensen, and thank you. Many do not know that you were the original drafter of the letter that we just showed on our screen, and the letter that has gone out, and just your interest and continued energy surrounding this issue. Talk to a little bit about what, if you had to talk to us about something actively we can do as a community. As you heard from Dr. Nabrit Stevens, there's both physicians and non-physicians on this call. How would you say that our next steps or things that we need to do, knowing that the Senate comes back this week?
Yes, and thank you for that question, because Sheila urged me to say that we need to be calling the Republican senators. And we probably need to just buttress Manchin a bit also to make sure that he stays in the right column. But she's urging us to really, where you have a senator, please call them and let them know that you want the bill that was passed in the House, a robust George Floyd Justice and Policing Act passed, and that you want that qualified immunity eliminated for law enforcement. So that's probably the most important thing. They'll be back in their offices this week. You can email and call. If you can write a letter, anything, but please get to your senators. And I think it's urgent right now. We had hoped we would have had it passed by May 25th, the anniversary of George Floyd's death. I think it's a shame, with all of the heightened awareness of what has happened and all of the people who have been killed even since George Floyd was murdered, that we're here in June and we still haven't passed it.
And just as a follow-up question to you, Dr. Christensen, if there's a senator that is not in our state, would it be okay for people here to call the senators from other states that they don't belong to urge them the same, or should we just stay with the state?
No, yes, you can call any senator, but of course they're going to pay more attention to those who are in their district. So if you're not in their district, but they need a call, and you have a cousin over there in a state where we may not have a local chapter or physicians, or people who are not non-physicians who are on this call, please, engage other people in other states to also make those calls. We need that, what Jess used to call street heat. We need some street heat. And the CBC and those who are negotiating need us to back them up.
Got it.
Let me go further. Can I ask a question?
Yes, sir.
Should anything be done extreme politically in regards to both Joe Manchin and Tim Scott? That's sort of loaded.
Well, it may take the next election to really do anything, but I mean, I know that both of those people have significant Black communities both of those people. And I think those two really need to get a lot of the pressure put on them to have this robust bill that we've asked for, along with the National Bar Association, to be passed. I've written to Scott before on different things that I thought he should take a position on. He and I share a birthday. I've never been he toes the Republican line to the dot of the I and the cross of the T. But he has constituents, and I was, even Sheila was trying to remember whether he was up for re-election soon or not. And I can't answer that right now, but he's going to be up for it. And yeah, a lot of pressure needs to be put on those two people.
I want to shift to Dr. Walks. Dr. Walks was so gracious to allow for me to move.
Can I just say one other thing? One thing that Scott is doing, though, whenever they get to reconcile the bills and come up with a final product, is to work. His job is to get the other 10 Republicans to vote to move the bill to the floor for a vote. And somehow it seems as though he's got his fellow senator involved in that. I don't know how reliable that is, but Tim Scott and Lindsey Graham are the ones who are supposed to be getting the 10 senators to allow us to vote on the George Floyd bill.
Dr. Walks.
Thank you, Dr. Mitchell. I want to make a comment first about how wonderful it is to see the strength, the intelligence, the integrity that we get on these issues when folks are not intimidated and able to speak plainly and tell us exactly what's going on and where the challenges are. This is not a choice, but I think sometimes we think that there's a choice we have to make between focusing on qualified immunity and focusing on prosecutorial discretion. I think we can want qualified immunity to go away, and we can work toward that, and we're talking about that, and it's important. And at the same time, we have to pay attention, as was said earlier, to what people are doing in those local decisions. You can come into court and claim qualified immunity, but I think, I'm not a lawyer, I think that somebody has to agree with you that this meets that qualified immunity standard. And I think we get to vote on who those people are in many of our jurisdictions. Am I way off base here?
You get to vote. That's what the political determinants are all about. Yes, you get to vote on people who share your position on this issue and other issues that affect our community. Absolutely.
Yeah, and
City council all the way up, even the Board of Education at every level.
And on this issue, Chauvin's case is a case where, the qualified immunity would not uphold, right? I mean, there were individuals that made a choice that qualified immunity did not apply to the actions of those law enforcement officers. So, but they are less egregious or less, there are circumstances where there's no video camera that occurs, and there's an opportunity for qualified immunity to be applied when you don't have as much evidence, and it's just as egregious is the point.
Mm-hmm.
So the both and is absolutely something that I think you're saying, the both and construct for prosecutorial discretion and qualified immunity, or the rating of qualified.
Right, and Dr. Mitchell, so often we get caught waiting. And I don't hear anybody who has presented today advocating for waiting, but we sometimes get caught waiting for the big thing to be fixed when the thing that we can work on is right there in front of us to fix it. So I just want to say how important this conversation is, as someone who has sat on a sidewalk with handcuffs on never been arrested, but I've sat on a sidewalk in my suit with handcuffs on. And now every day I wonder when I drive down the street, I wonder if they did anything. There once was a time when I said, I wonder what that brother did. Now I wonder if they did anything. And I think it's just important for all of us to recognize that this is a significant opportunity for us to have this conversation followed by some action.
Well, thank you, Dr. Roger Mitchell, Dr. Mallory Williams, and Dr. Donna Christensen. We certainly appreciate the subject and the expertise that you brought today. And we know that this needs to be not a one-time deal. We need to have more time to discuss this. And I'd like to offer you the chance to do that in the future, if you would, as well as make a podcast or a special presentation to our medical advisory board where we can get it even more real. Thank you so much. We're not done yet. We're at the top of the hour close. I want to remind everyone that on the 25th of June, the Black Health Trust is co-sponsoring the first international symposium on long haul syndrome. And for physicians on the call, you're able to get credit for medical education. The public is invited as well. We know that even though you've been vaccinated, if you've had the COVID, there's the potential for brain fog, for central nervous system effects, from cardiac effects, from renal effects. So it's not necessarily over when it's over. And we're going to present that conference to you in conjunction with the State University of New York Downstate Medical Center and the Brooklyn Center for Health Disparities. And Dr. Waltz and Dr. Barbara Neighbor-Stevens and I are involved in the planning for that. In addition, a number of our community needs second opinions on their medical diagnosis and suggestions, and we have made available to Biometrics second opinion expert, which can be found on our website, blackhealthtrust.org, to provide specialty physicians, primary care physicians who can answer your questions directly and assist you in your medical care. And we wish you would take advantage of that. In addition, we are officially a 501c3, and we need your help as soon as possible to help us continue with our program. And we're going to be adding, in addition to COVID-19, but the issues that affect communities of color. And this is one of the things that I'm so glad that Dr. Mitchell and his advisors brought to us today. We thank you so much. I know Dr. Pointer is on the phone. I don't think Ms. Brenda Lieger, but we have a tradition, and I'd like Dr. Pointer to take us out as soon as Dr. Barbara Neighbor-Stevens and Dr. Ivan Waltz have final words, and also Dr. Mitchell.
Ms.
Dr.
Ager
Barbara
is
Neighbor?
on, Dr. Maxey.
Huh?
Miss Ager is on.
Okay, well then we'll have her, but right before Reverend Pointer. Dr. Neighbor-Stevens?
You're on mute, Dr. Neighbor-Stevens.
Thank you. I would encourage all of our listeners and participants to continue to reflect on the content that we have covered today. And as you reflect, if you have comments or questions that you would like for us to pursue, I would encourage you to send those comments through the website, or you can send them directly to our virtual assistant. But get the comments to us, because this is not something that we are going to do a one-time pass by and leave it alone. This is something that will continue to require our energy and attention going forward.
Dr. Waltz?
Thank you, Dr. Maxey. Just to thank everyone and to emphasize that when we talk about public health, we absolutely talk about mental health and the challenges of what happens to those folks who know and love people that get into any sort of a challenge with folks in custody. Those scars are long lasting. You don't have to have someone seriously injured physically or killed to have profound consequences of interactions with custody. So I just want to highlight the mental health aspects of what we've been talking about today. And there was a comment in the chat about where can folks access what has gone on today. And I just want to remind people that the blackhealthtrust.org has all of the Black Health Trust programs archived and available. And folks should feel free to get to the blackhealthtrust.org site, not only to support the Black Health Trust, but also to look at what's archived there.
In addition, they're archived on YouTube as well. Additionally, I'd like to say, I am so happy that we're able to bring the level of expertise that's presented here. Every week, some of the top physicians, scientists, and other health professionals are represented here. And the majority of them are Black. They're from your community. They are the trusted messengers. If you go back and look at our history, at our archives, you will see some of the outstanding physicians in the world making presentations. And most of us belong to the National Medical Association because the National Medical Association was established in response to the 1895 verdict that Blacks could not join the American Medical Association. I'm glad they didn't let us join. Now we have a premier educational organization there is represented by Dr. Mitchell and Dr. Donna Christensen and also Dr. Williams and others that you've heard every week. And I noticed many of them on the line now, Dr. Gary Dennis, one of our past presidents and others. So look for the outstanding trusted messengers that we bring every week. Thank you so much. I'd like Dr. Brenda Lee Ager, followed by Pastor Pointer, to bring our program to a close for today. And I like the suggestion, if it's Sunday, it is the Black Health Trust. Ms. Ager? Can we make sure she's unmuted?
There we go.
It took me on back to my Operation Breadbasket days today. Ain't gonna let nobody turn me around, turn me around, turn me around. Ain't gonna let nobody turn me around. We're gonna keep on a walk, keep on a talk, walking up the freedom's road. And you know that. So with that, thank you all the wonderful speakers today. Get me on fire. God bless us all. Keep us all and make us all aware. Knowledge is power, and we become more aware of who we are, whose we are, and make a change in this world.
Amen.
Amen.
Reverend Pointer, let's get him unmuted, please. There we go.
All right, thank you. Let us look to the Lord. Eternal Lord, our God and our Father, first, we thank you that you granted unto us another time of sharing in a fellowship together, that you sent your servants, Congresswoman Dr. Donna Christensen, Dr. Roger Mitchell, and Dr. Mallory Williams. Thank you that we've had this time to learn again what we have known instinctively and statistically, but being reminded and called to a place of action. So use our hands, use our voices, let us be the instruments of your peace. Finally, allow us to be perfect, be of good comfort, be of one mind, to live in peace. And we know that you, the God of love and peace, will be with us. The grace of the Lord Jesus Christ and the love of God and the communion of the Holy Spirit be with you all. Amen.
Amen.
God bless you all. This
Amen.
has been great.
Thank you to our speakers, Dr. Mitchell, Dr. Williams, Dr. Christensen. Thank you to our virtual assistant, our production assistants, our graphic artists, and my two fantastic co-moderators, Dr. Barbara David Stevens and Dr. Ivan Walks. Thanks, everybody. Have a good Sunday.
Amen.
Bye, everyone.
Bye-bye.